Hello, everyone. Happy Wednesday. Welcome to the next edition of our Laser and Skin Surgery Center webinar series. I am so excited that today we are here with Dr. Hoffman. Hi, Dr. Hoffman.
Hello, how are you?
So Dr. Hoffman is one of our newest doctors to join the practice. He is a board-certified plastic surgeon, and I see a lot of you getting settled right now, so I'll just give you a minute or two to get acquainted with Zoom before I start the webinar. So on the bottom of your screen, there's a few options. There's an option for Q&A, and that is where you can start populating any questions that you specifically want to ask Dr. Hoffman. You're welcome to pop them in now if you already know what you want to ask, or as he's speaking throughout his presentation, and then we'll get to as many as possible at the end. There is also a chat feature if you have any questions for me, but ideally the Q&A that you really want Dr. Hoffman to answer can go in Q&A. So, all right, without further ado, again, welcome to the Laser Skin Surgery Center webinar with Dr. Lloyd Hoffman. He is a board-certified plastic surgeon who recently joined our practice. He's born and raised in New York City. And he has had a lot of appointments both in academia and in private practice. He was also notably chief of plastic surgery at York-Presbyterian Hospital. Fun fact, he was actually the youngest chief of surgery anywhere in the country at that time. His training was at Cornell and NYU, and we are just so proud to have him at Laser Skin Surgery Center. It really rounds out our ability to offer any and all of the cosmetic and aesthetic needs that you might have. So without further ado, here's Dr. Hoffman.
Good evening. Thank you so much, Risa. I really appreciate your help in organizing this. Good evening, everyone. I'm Lloyd Hoffman, as you know already, and I'm truly grateful to meet all of you, albeit electronically. For my old patients, you know how much I appreciate you being here, and for the new patients, so welcome aboard. We're going to be talking about face and neck lifting this evening. But before we get into that, I'd like to spend a couple of minutes talking about my practice philosophy. Obviously, as a physician, do no harm. We don't want to make anybody worse, that's for sure. I'm a firm believer in a conservative approach. If you really want to change everything about the way you look, you're not in the right place. You need to go someplace else. I think it's important for me as a physician to understand what you need, what you would like, and what your expectations are. And I think the failures that we see in plastic surgery many times are the plastic surgeon not meeting the expectations of the patients and vice versa. I think it's important to maintain the proper atmosphere, decorum in the operating room. I take operating incredibly seriously. No one else touches the patient other than me. Surgically, there are people to help me, but when you agree to have surgery and I agree to take care of you, we're going to work together on this. And I'll never leave you alone from the time you come into the surgery center or the hospital and the time your family picks you up or a nurse takes you home or whatever it is. You will never be alone. I think the follow-up care is extremely important in what we do. My wife had surgery and spine surgery, and the orthopedic surgeon came by to see her the next day, and he said, well, you look great, I'll see you in 6 weeks. My patients want to see me every 5 minutes, and that's okay. You know, I'll see you as often as need be. You'll have my cell phone number, and I'll always be available. So those are the kind of the ground rules. Throughout my career in plastic surgery, I've done surgery for sure. The last 10 years or so, all of us have become familiar with the non-surgical approach to plastic surgery. Now, you had the opportunity for those of you who have followed these webinars to listen to my distinguished colleagues, Dr. Geronimus and Dr. Shelton, and they are truly amazing. They do wonders with the non-surgical treatment. I like fillers a lot. I like Botox a lot, and I'm very comfortable with those modalities. Not too long ago, I had a patient who I went to see in the exam room. She's got a very good sense of humor, and I know her for a long time, and she's lying on the table, and she says, "Okay, Hoffman, fill her up." So it's, for me, it's nice. It makes a big difference right away. Botox takes 2 to 7 days to kick in, but the fillers are immediate, and we all love immediate gratification. For tightening of the neck non-surgically, you can talk to Dr. Geronimus and Dr. Shelton about radio frequency. I don't do that. Jowling is tough. They use radio frequency for that. Sometimes I can camouflage the jowls with filler. What I really love are the cheekbones with Voluma. It makes a world of difference right away. Botox, of course, in the usual areas, the brow, above the nose, between the eyes, and the crow's feet. And we're going to talk about the double chin. Laser resurfacing. These people are truly amazing. I think there are about 100 lasers in the facility, and what I was struggling with for years, they take care of very quickly and very easily. So I defer to them many times for laser therapy. Well, when is surgery a better option than the non-surgical means? Obviously, if you have significant jowling, sagging skin, a difficult neck, if you're looking for a more permanent solution, you're looking for a single procedure, and obviously if you want to do reshaping, major reshaping, that cannot be done with fillers alone. So when you start to see the jowling, the sagging skin, it's time to at least consider your surgical options. And although I offer surgical and non-surgical approaches to the facial rejuvenation, I think the vast majority of patients will require both, and they really benefit from a blending of the non-surgical and the surgical. It's important for us to understand a little bit of the anatomy when we consider a facelift. And let me start by saying a facelift really includes the neck. People say, well, I just want the lower face, but the vast majority of times, a facelift includes the neck. It's basically one unit. And when I was teaching a lot, I would make sure that the residents and the students understood the anatomy perfectly, because anytime you take it upon yourself to make an incision on somebody, you better know what's underneath, okay, to stay out of trouble. And basically, the facelift is a combination of a skin lift and this submuscular aponeurotic system, otherwise known as the SMAS. And these are the two main layers. For what are called deeper plane facelifts, we get involved in the retinacular ligaments. But for the most part, we're involved with skin and the SMAS. And we worry when we do a face. I worry all the time. I'm nervous all the time about what's underneath what I'm doing. Here you see lifting up the face, up the skin of the face, and we have a window into that SMAS layer, and we see these nerves. Now, we have to pay a tremendous amount of attention to this. When we make our incision, you can see how close the nerves are to the skin. And there are two nerves, the one up here, the temporal branch, and the nerve down here, the mandibular branch, are incredibly important, and we do everything we can to avoid any type of injury to those nerves. And just in general considerations for facelifting, the earlier the facelift is performed in the well-selected patient, the longer lasting are the results. The patients with better facial proportions will have better long-term results. Skin resurfacing with laser appeal during the operation helps. Fuller necks have earlier and higher relapse rates. The necks, although they're my favorite part of the operation, it's the most difficult. People who have fuller faces and less deflation, the results tend to last longer as natural volume is preserved. And we're going to talk about opening the neck in a few minutes, but if you have bands in your neck and you're getting a facelift and you don't address those bands in the neck, they're just not going to go away. And we want some kind of long-lasting result. But again, that's the most difficult part for me. And males and females have similar results. What's involved with anesthesia? Well, anesthesia has come a long way in the last 30 years that I've been operating. We can do these cases under general anesthesia, IV sedation, or local anesthesia. That means just injections into the face. My preference is to use something called an LMA. When the anesthesiologist puts this into your mouth, it doesn't go down your throat. You get sedation with this, and you're breathing on your own the whole time. When the operation is over, they just lift this out, and you're awake. If we can avoid using a general endotracheal tube, that is a tube down your throat, I like that much more. And local anesthesia, straight local anesthesia, I've done it, but I must tell you the results are suboptimal. To be on the operating room table for 3 or 4 hours without sedation is very difficult. It's very difficult for the patient and very difficult for me. Obviously, we try to protect the eyes. We put in shields or tape the eyes. We secure the tube. We use a mixture of local anesthesia to inject under the skin. It helps our dissection, lifting up of the skin. It makes it much easier and less pain afterwards. And sometimes for cases that I think that might be, for whatever reason, more than 4 hours, it's important to put a catheter in the bladder. That's taken out before you wake up, so you never know that it's in, but it prevents your blood pressure from going up and causing issues during the surgery. The incisions for the facelift are well hidden. They heal generally quite nicely. They start up in the hairline and they come down around. Now, sometimes we go in front of the ear, sometimes we go into the ear. There are advantages and disadvantages to both. This is not a great scar. It's white. Most of the time it heals without this white scar, but there's no distortion of the ear. Sometimes if you try to be cute, too cute, and come behind the ear and then around and then to the back, here you see the back incision. That incision in the ear causes distortion of the ear, and it looks weird. So here we are. I like a zigzag approach, and that saves the hairline. A dead giveaway to a facelift is when the hairline moves up, and it's just terrible, and patients have a bald spot here. You'll often see that in what we call secondary facelifts that have been done again. But it's my practice to go along here. I use this zigzag incision. It heals quite nicely. By beveling the incision, you're able to save the hair follicles, so the hair will continue to grow there. And this sideburn does not move up, and the patient doesn't look silly. For getting into the neck, we will often use what we call a submental incision. Again, this heals quite nicely. Again, being in a laser center, if these lines are red for longer than we would like, we have these wonderful lasers that can take away the redness in 1 or 2 treatments. It's absolutely painless and it works amazingly well. Over the years, we've given a lot of thought to the direction of the pull or the direction of lift of the face. We used to pull the face back, and that was a windswept look. You'd walk along Madison Avenue and you'd see all these people with these pulled back faces, and it looks absolutely horrible. It's just, it makes sense that we should have an upward pull, because that's where all the tissue was, that's where it's dropped down from, so it makes sense to have an upward pull. And we secure, we put in key sutures here and back here, and that's where the main tension is. You don't want a lot of tension in the facelift, and certainly not in the earlobe. We don't want a pixie ear. So what we try to do is pull it up, and sometimes we angle it a little bit back, so you get the best of both worlds, but certainly not straight back. If anything, more up than back. This is a patient not of mine. This is a patient from the internet, but I just wanted to show you that how important it is not just to lift up the skin, because if you just lift up the skin, pull it and trim it and secure it, it's not going to last. I mean, some of you may remember the lifestyle lift that was popular a while ago. Well, that was just a skin lift. And needless to say, they went out of business. So I think it's important for us to lift up this layer, secure it, either by using sutures all the way around or certain key sutures, but it needs to be secured. And it needs to be secured in this direction and in this direction. And that's your best bet on trying to get the facelift to last. We do male facelifts. You have to choose your patients very carefully because of short hair. The incisions can be visible. I operate on a very well-known radio personality with a great sense of humor. He said, "I love the facelift, but I have to shave behind my ears." That's right. The beard goes behind the ears, so that needs to be shaved. Certain considerations in a male facelift, they tend to bleed more. So we see more what we call hematomas, or accumulation of blood. Their whiskers, for each little facial hair, there's a blood vessel. So you can imagine how much bleeding you see underneath. And again, we try to hide the incision as best we can. Now, we talked about moving from the non-surgical to the surgical. Now, a lot of my patients would prefer not to be photographed, and I respect that. So this is a patient who I did a facelift on. She had tried non-surgical means, but when you have this hanging skin, there is just no way that with radiofrequency or fillers or laser or dermabrasion or anything that you're going to get this kind of result. Now, post-operatively, could she benefit from laser treatment? Of course. That's what I was referring to about the blending of the non-surgical and the surgical. But when you have something like this, we need to really consider the surgical options. One of the questions that I'm asked is how long do they last? This is one of my favorite patients, and she came to me 5 years ago for a facelift, and this is what she looks like today. Again, have the jowls. There's just no way that you can proceed with the non-surgical. And the hanging neck skin, You got to do it. You got to fix it. There's another favorite patient of mine, and she was kind enough to take a photograph every day for 2 weeks of her recovery, just to give patients an idea of what they're in for. So, day 1, you're wrapped. Sometimes there's a drain which comes out day 1. The most important post-operative care here is ice. We like frozen peas. Many times the patient will go home with a nurse or someone in the family who can watch them closely and make sure they're iced. She had minimal bruising early on. This is not always the case. Sometimes you'll see some bruising here. And again, one of the benefits of being at the center is that we can use lasers to deal with bruising. And the repair is apparent within hours. It's truly amazing. She did not have that. We happen to be lucky here. But you can see the face and eyes. I can't show your eyes, but her face starting to take shape. And she was very pleased, and I'm very grateful to her for allowing me to share this. You know, part of the facelift, as I said, is the neck. It's a vital part. And neck contouring is one of the most frequent reasons patients seek cervical facial rhytidectomy. That's facelift. Because neck tends to be one of the areas that goes first. And what are the criteria of a youthful neck? I think this is the most important one, this angle here. When people start losing this angle, they start getting upset. And that's when they start to show up in the office. It can happen in the late 50s, it can happen earlier, later, but this is the key right here, this cervical mental angle. Yes, you want to see the muscle here, you want to see the thyroid cartilage, you want to see all these things, you want to see this mandibular border. Patients will say to me, well, you know, what happened to my jawline? It's gone. So that's what we try to do in the lower face and neck. Try to recreate the jawline and try to reestablish this angle. So what are the approaches to neck lifting? This is a lady who's not going to benefit from anything non-surgical. There's liposuction for mild cases. We can do a direct excision, which I'm almost passionate about. There's a neck lift, which we do without the facelift, and there's a neck lift that we do with the facelift. And it all depends what your goals are and what the anatomy is. I see a number of older patients, men and women. Men say their grandchildren play with their waddle, and it makes them crazy. And this woman, she could have used a facelift for sure, but she didn't want it. She just didn't want the downtime, the 2-3 weeks. She felt it was a big operation. She didn't want to change her looks, afraid what people would say. And by the way, speaking of afraid what people will say, people ask me, well, will I look totally different? I said, no. My role is not to have people ask you who your plastic surgeon was. People should say, wow, you look rested. Where'd you go on vacation? That should be the goal. Anyway, this lady, I suspect they saw a difference. I don't know. But she underwent a direct excision. And what I mean by that is under local anesthesia, maybe minimal sedation, I can draw a line here and draw a line here and just actually remove this skin and sew the two ends together and do a little bit of excision here and a little bit of stuff down here, and I wind up with this, which obviously it's a scar and they have to be willing to accept the scar, and you're looking at it close up, but if you're at conversational distance, nobody's going to really see this, especially if you use a little bit of makeup over it. But when you compare this to this, it's a no-brainer, right? Especially if you don't want the whole thing. Here's another one. This woman is a little younger, all right? And I'm a little bit hesitant to do it in younger patients because they don't heal quite as well. You're better off with women and men in their 70s and into their 80s. The scar is a little bit raw, and I'm going to have to work on this with the laser to make this better. But I did want to show you a direct excision from a younger patient. Lisa, if I'm taking too much time, you just tell me.
No, you're doing great.
Okay.
But while I'm here, if anyone does have any questions, Dr. Hoffman's giving so much info. Again, you can use the Q&A function because when he's done, he's going to be available for you. Okay.
Now, oftentimes we combine the neck lift with the facelift, and again, the incision comes around the hairline, either into the ear, around the ear, around, and then to the back. The back is a little tricky in women who like to wear their hair up. You have to warn them that there's going to be incision back there. Again, it heals nicely, but if you're going to wear a tight ponytail, you know, it may be obvious. So that's something to take into consideration, and we can get around that. We can go back into the hairline this way. The pull on the neck is not quite as good, so everything in life is a trade-off, so we have to make that decision. But this was done in we do it in one stage, face and neck. Okay, let's talk about some of the complications. Anesthesia risks. I think these are incredibly low. People ask me, what is my risk of dying from anesthesia? It's probably the same number as it is walking out of my office and, God forbid, getting hit by a truck. It's incredibly rare. I think the horror stories that you've heard are people who have their surgery in, I don't want to say non-accredited, but smallish surgery centers may not have quite the facilities, but you want to be in a well-equipped place to deal with any eventuality. But the anesthesia risk is incredibly low. I always worry about bleeding. You need to stop your aspirin at least 2 weeks before. We can't do this operation in patient on blood thinners. But in the normal run-of-the-mill patient, bleeding is extremely rare. Every once in a while, there's a little bit of blood under the skin, which I aspirate, and it goes away, and it's not an issue. Infection is extremely rare. We give you antibiotics at the time of the surgery. There are no antibiotics after the surgery, and you don't need any oral antibiotics. Poor wound healing and skin loss is incredibly rare. I've seen it once in over 30 years, and the patient went on to heal quite nicely. We talked about the anatomy and the nerves we watch out for. Again, we don't want to pull the incisions too tightly because that's where you see the hair loss. Spoke about fluid accumulation. Most of the time it's blood. Numbness, I prepare the patient that you will be numb for at least a few months. You lift up the skin. There are tiny little nerves which are interrupted, and it takes a while for them to grow back. So that's to be expected. What are some of the associated procedures that we do with facelifting? We'll do laser at the time, and most of the time it's perioral around the mouth. Remember, anybody who's had cold sores, you'll need to take Valtrex. We don't want to risk any outbreak. But this I'll do at the time of surgery. We cannot do the rest of the face, although she'd obviously benefit from it. We'll have to do that afterwards, because anytime you lift up skin, you can't laser it because you'll burn right through it. And that makes sense. Here you can see how well the incisions have healed, and they're hard to see. Liposuction of the neck, oftentimes at the time of facelift, I'll do liposuction instead of opening the neck. Or you can do this as a freestanding procedure for patients who have a double chin. People say, well, what will happen to the skin? If you have a minimal amount of skin, it won't be hanging because you need this skin to kind of redrape over the area where the fat has been removed. This is a patient who had liposuction, younger patient, no facelift, freestanding liposuction. This was performed by my esteemed plastic surgery colleague at the center, Will Brown. Excellent result, life-changing. Over the last few years, I've become very interested in lip lifts. I think this could make a huge difference. If you have a long lip, longer than, let's say, 2 centimeters, it looks a little bit strange. It kind of gives you a long face look. And a lot of patients have this downturned mouth, and it looks sad when they're not really sad. And we can do this at the time of facelift or freestanding. If we do it freestanding, I do this in the office under local anesthesia. It takes about a half hour. Huge difference. This incision heals quite nicely. It's in the nasal sill, and this is along the lip line. Again, heals quite nicely. Oftentimes at the time of facelift, patients will say, should I do my eyes? Well, it depends on how bad the eyes are. If there's going to be incongruity between the face and the eyes, it makes sense to do the eyes at the same time. It prolongs the operation a little bit, but it's one recovery period, one anesthetic, and you don't have that incongruity. And this is a lady we did the eyes at the same time. There are times where a patient would benefit from a chin implant. I use a very small chin implant. You can go either from inside the mouth or that lower incision that I showed you before, and both of them heal quite nicely. This is a reconstructive patient, just to show you that we can use facelift techniques for all kinds of patients. This is unfortunately a lady who sustained trauma, the right side of her face, and it's taken several years, but although she still has some scarring and will still need some excision here, she's come such a long way with the facelift and fat grafting and filler, and I'm incredibly proud of her. She's done amazingly well. So this is Celine, the love of my life, and she's saying goodnight. And this is, if you want to reach me, please feel free. Contact me at any time. And I think what I would like to leave you with is that it's highly unusual to have plastic surgery and dermatology under one roof, and to be able to offer, what I think is the best of both worlds. So you shouldn't hesitate to contact our office, and we can talk about this global approach or any questions or concerns you might have. I'd like to say goodnight, and again, as Risa said, I'm happy to answer any questions. Thank you so much for joining us. If you want to hop off now, and I so look forward to hearing from you. Good night.
Great.
Stay safe.
Thank you so much, Dr. Hoffman, but please don't hop off now. We have lots of good questions, and Dr. Hoffman's going to give us all of his answers. But if anyone does hop off now, the recording will be available, and we'll be sending it out via email this weekend. So the questions are coming in. To start off, do you perform lateral skin platysma displacement with fat grafting?
So there are many new procedures which center around revolumizing the face. And I didn't get into fat grafting, although we're doing a fair amount of it. We can do it either at the time of facelifting, or we can do it during the postoperative period. I'm pretty conservative, and I like to see where the patient needs it the most after the facelift, because lots of times it's difficult to predict. So we'll do fat grafting in the office under straight local anesthesia. But I feel better knowing that I can put it where I need it. Now, there are some times where it's obvious that I'm going to need fat grafting, and I'll do it at the time of the facelift. This lateral displacement of the platysma is rather new. It's pulling up of the neck laterally. My philosophy, and traditionally I've sutured the neck in the central portion, and that works well for me. But I try not to jump on any bandwagons.
Okay. Great. All right. I'm going to close down Dr. Hoffman's screen so we can see him a little bit better. So if anyone wants to take a quick screenshot or jot down the number, please do so at this time. Okay, so here's a good question. Where do you operate? Is it at Laser Skin Surgery Center?
So for minor procedures, I'll do it at Laser Skin Surgery Center. We have the ability to have an anesthesiologist there. However, for a blepharoplasty or facelift or neck lift, I'll do it in one of two surgery centers that I really like. I work with anesthesiologists who have put me to sleep, have put my wife to sleep, people that I really trust. And these are on the east side of Manhattan. I also, for the bigger reconstructive cases, I still operate at Cornell.
Great. Okay. Here is a good one. Is there a better time of year to do a facelift? For example, winter versus summer?
That's a very good question. I've you know, it's hard to say. I think the best time to do a facelift is when you can get the time off. I think that's the best time. You know, we used to say, well, direct sunlight is not good and all this, but you know, by wearing sunscreen and a large hat, you can do fine. Some people in the winter like that time of year because they can wrap their head in a scarf when they go out. You know, but I think that rather than you feeling pressure and the surgeon feeling pressure to get you where you need to be, I would say when you can devote your time and energy to this, that's the best time to do it.
And I might point out that that could be right now during COVID when we're all home, quarantining and wearing masks. A lot of patients are actually coming in now because this is a perfect time to cover up. Okay, the second part of her question was, how do you make sure that the mouth comes out naturally?
Yeah, also an excellent question. I think the way to do that is with the vertical pull. The vertical pull, you're not going to distort the corner of the mouth. You're going to get into trouble with the corner of the mouth when you pull laterally. That's what's going to get you into trouble. So if you don't want to change the architecture, I think it's more of a vertical pull.
Here's a good question from Susan. Is mask wearing now due to COVID going to be problematic post-surgery?
No, I don't think so. It's interesting. I saw a device online, which I think I'm going to get for my patients. Because the incision goes around the ear, I was thinking about these masks that have the loop around the ear, and maybe that would be irritating. Well, there's a device that I saw. It's a piece of plastic that has little notches in it, and you put it behind your head, and you hook the mask onto those notches so that it's not around your ear. I thought that was brilliant. I'm going to use that.
Yeah, I think that might be nice for a lot of us. It gets uncomfortable back there. Okay, here's a good question. Does it help to do laser resurfacing a few months before a facelift?
Yeah, I don't think that's a bad idea. I think that if you have the time, again, if you have the time, it's not unreasonable to do it. Sometimes what I've done is if a patient has 3 weeks to recover, I'll do it in the office 2 weeks after surgery, and I can do it anywhere on the face. Remember, I said that if you do it at the same time, you can only do one area. But there's nothing wrong with it there's nothing wrong with doing it preoperatively. Absolutely nothing.
Okay. All right, here's a good one. This is from Nina. Can you discuss blepharoplasty in a patient with dry eyes?
Ooh, that's a tough one. That's really a tough one.
All right, Nina.
I spend, what is dry eye? Well, dry eye means that you don't have very good tone in your lower eyelid. So that anytime you make an incision, whether it's inside the eye or outside the eye, you run the risk of the eyelid being pulled down. And that's not a good look. You don't want that. So basically, if the patient comes in and says either they have dry eye or they give a history of their eyes tearing when they walk out in the wind, or if when I examine them, they don't have a very good snap test, in other words, I pull out the lower lid and it doesn't snap back, those are all red flags. And what that tells me is that the patient needs to see an ophthalmologist to document the amount of tearing that they have, the amount of dry eye that they have. And then we might make some adjustments in our operative plan. If it's mild, that's fine. I can deal with that. I can tighten the lower eyelid and protect the eye. That's not. If it's severe, you may need an oculoplastic surgeon who might be more well versed in dressing the lower eyelid.
Okay, that's helpful. All right, so here is another good question. So I am past 88 and don't want to go under any more surgeries. My lip area was swollen after a filler, and I'm curious if I could do fat transfer to put it in my marionette lines where the doctor put in Vitrace, which took out too much.
Wow, you sound like a veteran, huh? Yeah, Vitrace is very helpful for dissolving any lumps that you might have. We rarely use it, but it does work very well. And yes, if you do have fat, we generally like to take it from the abdomen. I think you'd be a great candidate for it. Assuming you're not on any blood thinners or anything else, you don't have any significant cardiac problems, yes, I would be comfortable doing a fat transfer under local anesthesia.
Okay, and she says, would I need to go into a hospital and would I need to go home with a nurse?
So we don't do these procedures in the hospital for a couple of different reasons. Number one, the exorbitant expense of a hospital. You just can't imagine what an operating room costs for 4 hours in a major hospital. The other thing that I find is that the anesthesiologists who work in the surgery centers are more accustomed to doing these kinds of cases, and they're very slick. Patient wakes right up at the end. So for those two major reasons, that's why. And now people are hesitant to go into the hospital, but that's a whole separate issue.
Okay. So here's a good question about lip lifts, the tongue twister. Do you have a lot of experience doing them, and what are the risks? How long do I need to plan to be in New York if I come to see you from Florida?
I would like to have you here for, I would say, 7 to 10 days. The sutures stay in 7 days. I'd like you to be here another few days after that, just to be sure everything is okay. I like the procedure a lot. I've done a number of them. It's very well tolerated. It takes me, most of the time is actually, honestly, designing the incision. The surgery itself is very easy. But it's the markings which take the time. But I think that if you have a long upper lip and you don't have much mucosal show, the redness, it would help a lot. And you can do that. I think the non-surgical attempts in that to inject filler into the lip look ridiculous. I mean, you can do lip enhancements mildly, but for this long lip, it just doesn't work. And for older patients where the lip is almost completely hidden, There's just no way. Young patients who want lip enhancement, that's great. But for the patients who are walking around with this, very little show, doesn't work. You need a lift.
Okay. So how long do you think she would need to stay in New York City? This person's now coming from North Carolina.
10 days.
10 days.
Now, I have had patients, I had one patient had a lip lift, went back to North Carolina, and then came back for suture removal. So, you know, you don't have to be in New York the whole time. Whatever works. But I do need to see you 7 to 10 days later.
All right. Do you often incorporate laser work into the package of a surgery?
Sure. You know, whether you need it for your scars or something else, bruising, that's all part of it.
Okay. All right. This is a good question about chin implants. Can you talk a little bit about what a chin implant entails? What is it made of? Are there any drawbacks? I have drooped jowls, but my chin and jaw are proportionately skimpy.
Okay. Yeah, so again, without seeing you, that would be difficult, but it sounds like you benefit from elevation of the jowls through the facelift. You might require fat grafting in that area, and it depends on how deficient you are in your chin. Either we can accomplish lifting the chin with fat or with a silicone implant. It's solid silicone. There are no issues with the silicone itself. Rarely the implant can shift, but an infection is incredibly rare. So you don't want an implant that's too large. I just did a facelift on a lady who had an old implant and it was just too pointy. So we used an implant that had these wings on it. And it sounds like you may be a candidate for that. When we do use fat in this area, it can resorb. About 50% of it disappears after a year. So sometimes you have to do it again. But again, without seeing you, that would be my answer.
Okay. How do you decide if a patient needs fat transfer to achieve more fullness when you're doing a facelift?
Yeah, as I said, it's a difficult call. The areas where we like the fat are over the cheekbones, along the jawline, and in the temporal hollows. If patients present with severe deficiencies in this area, I would say, why not? Let's do the fat transfer at the same time. You may have to touch it up later, but if there's an obvious deficiency in those areas, and those are the most common areas that we do, also the nasolabial fold as well, right in here. Those are the most common areas we do it in. If you're obviously deficient, it's a good time to do it at that time. And the way we like to do it is we harvest the fat, generally from the belly, through a little bit of liposuction, let the fat stand, we process it, and then by the end of the facelift, we're ready to inject.
Very interesting. Okay, so you've kind of already answered this, but Valerie's asking, she has a port wine stain on the side of her face. She'd like to come in and get laser surgery, and she's wondering if she could get a neck lift at the same time, or if it would be two separate surgeries.
Yeah, we have to, I have to investigate that. One of the surgery centers that I've been operating on at has a number of different lasers, and I'd have to see if the laser would be amenable to the port wine. The problem with that is, yeah, we certainly couldn't lift any of the area that was going to be lasered. So I think there's a good possibility that we could do both at the same time.
Okay, so I guess
we can do it at the center and then, at some point do the neck lift. Or if it's not a huge neck lift, we might be able to do the neck lift under local anesthesia with a little bit of sedation in the center and do the port wine stain by Dr. Geronimo or any of the other geniuses that they have there.
Okay, perfect. All right, so a lot of you are asking about ballpark costs, and I want to say that that's really too difficult of a question for us to answer. Really, it needs to be done on a one-on-one basis because Dr. Hoffman individualizes and customizes the treatment so much, like he's been saying. Does it include fat transfer? Is it a neck and a face and so forth? So if you don't mind, please reach out to us so we can discuss that with you individually. Okay, this is a great question. Do you determine the need for surgery versus non-surgical intervention, or would a first visit to someone like Dr. Shelton or a non-surgeon be preferable?
Well, you know, we work so well together that I don't think it really matters. You know, if you're leaning towards one or the other, and hopefully by, you know, the end of this evening, you'll have a better idea of whether you're a candidate for one or the other. If you think that you'd like to investigate the non-surgical world, you can see Dr. Geronimo, Dr. Shelton, Dr. Belkin, and just any number of these people, and they will advise you. If they feel like you're a surgical candidate, they'll grab me and say, Hoffman, we got somebody for you to take a look at, and I'll just walk across the hall and take a look at you and give you my honest opinion. If you come to see me and you tell me that you're interested in radiofrequency or threading or something like that, you don't want me to go near you, and then, you know, I'll give them a call. So that's the way we work.
Yeah, it really is the best of both worlds, because if you come to the Laser Skin Surgery Center of New York, since we have dermatologists and plastic surgeons, no matter what direction you go, we'll be able to help you, which is great. Okay, only a few questions left. Thank you for those of you that are sticking around. So a quick question, how many months for a facelift with the neck to completely heal?
Great, get that question every day. Again, everyone is different. I would say the patient I showed you, 2 weeks, she's good to go. I tell patients that's the average. Some patients need 3 weeks for the bruising and the swelling to go down significantly where you don't mind being seen in public. I don't think you're going to start to see the real result for 6 weeks. I really do. I think the swelling will come down, and it continues to change for a year. But certainly by 6 weeks, you'll be in good shape. Now, people plan these procedures around major life events, good events. So, you know, if you're thinking, oh, I have my daughter's wedding coming up, you might want to give yourself at least 2 or 3 months prior to doing that. But I would say 2 to 3 weeks for the initial swelling and bruising, 6 weeks to look great where you can go out socially, and then 6 to 12 months where you see the final result.
Beautiful. Okay, last question. What would make you choose a fat injection over a filler?
Wow, that's really a good question. Our techniques in fat grafting have really evolved, and we're getting much better results with fat grafting now. We understand how to process it, how to inject it. And that's appealing to a lot of people because it's your body. Sometimes it doesn't take completely. And you might not get, at least in my hands, you might not get as excellent a correction as you would with filler. Now, filler, of course, depending on what you use, for example, Voluma for the cheeks can last anywhere from 12 to 18 months. Other fillers last 6 to 8 months. So, that's the downside for sure. But I can be much more precise when I'm filling in the cheekbone with the Voluma. than I can with fat. And that's me. Other plastic surgeons may feel differently. I like the fact that it's your own tissue, and that it becomes incorporated into your body. And when it takes, it's there for a long, long time. If it doesn't, you got to repeat it. So it's really dealer's choice.
Okay. All right. Well, thank you so much, Dr. Hoffman. Thank you, everyone that tuned in. Again, Dr. Hoffman, this was incredibly educational. I hope you all found it useful. This is recorded, so we will be sending out this weekend so you can look at some of those diagrams again and those impressive before and afters. It was also streaming live on Facebook, so you can head there now if you want to see it. And please, feel free to call us, email, or visit the website if you'd like more information. Dr. Hoffman or any of our doctors would love to meet you. You will be getting a survey when we shut this down. We'd love your feedback so we can continue to improve. And otherwise, any final words, Dr. Hoffman?
No, have a good night, stay safe, and thanks for joining us.
Thank you, everyone. Bye.
Bye-bye.